Second session. So it's just noon, so we can say good afternoon to all of you. My name is Andreas Petropoulos, and I have the honor to be the first elected General Secretary of our association. And I want to welcome you also to Athens and to our first International Congress. With the prestigious colleague, Dr. Konstantinos Bratis, who is a lead in imaging, we have the honor to chair this session on maybe the most important of all the valves in the heart, the aortic valve.
Good afternoon. It is my pleasure to be part of this conference and of this discussion with distinguished speakers, and I'm sure that we'll have a very interesting discussion on the aortic valve, congenital aortic valve disease in the following 2 hours. Would you like to introduce?
Yes. So the first speaker will be again Professor Robert Anderson, who does not need an introduction because he is the father of the morphology of cardiac congenital heart defects, I would say worldwide, but probably he will be more humble and say only in the European continent and the ex-Great Britain area of interest. So, do we have the presentation of Professor?
So, ladies and gentlemen, it's a pleasure to join you again and to move on to the second of the anatomic presentations. And this time I'm going to be discussing with you the aortic root. And what I want to begin by emphasizing is that the aortic root is the centerpiece of the heart. And we can see that most beautifully in this segmented computed tomogram that was prepared for me by Shumpei Mori. I worked with Shumpei for quite some time. He's now an anatomist and a cardiologist in his own right, working at the University of California in Los Angeles. And he prepared for me this beautiful segmented computed tomogram put into the setting of the chest radiograph. And there beautifully you see the aortic root giving rise to the coronary arteries. And you note that it is posterior and to the right of the pulmonary root. But you also see very nicely how the non-coronary leaflet of the aortic root is wedged between the orifice of the mitral valve, which we have just discussed, and the orifice of the tricuspid valve, which we will be discussing very shortly. So the essence of the aortic root, it is related to all 4 of the cardiac chambers. So how do we describe it? So here I bring you to this quotation from John Maynard Keynes, of course was an economist, and he made the point that when discussing economy, we had to escape from the old ideas if we were to believe in the new ones. And it's exactly the same when we come to describe the aortic root. So quite some time ago now, 13, 14 years ago, the German surgeons produced a questionnaire, and this was the result of their questionnaire. And when they published their findings, you see that at that time they described the nomenclature as a Tower of Babel. And hopefully we've now gone some way forward in sorting out the problems found within the Tower of Babel. And the problems reflect the words we use to describe the aortic root, because I do not believe that those words are used as they ought to be used, which is the way they are defined within the dictionary. So what am I referring to? I'm referring to two particular words. The first is the cusp. Now, if you go to the dictionary and you look for the vernacular meaning of cusp, you will find that it is a pointed end, particularly where two curves meet. The other term that gives me difficulty is commissure, because strictly speaking, a commissure should be the zone of apposition between two parts, as we see in the bones of the skull, or the line where the upper and lower lips or the eyelids meet. And as I'm going to show you shortly, sadly, this is not how we use it in the setting of cardiology. Let me illustrate the problem in the setting of the aortic root. Now, this is an opened aortic root. Picture was taken by my friend and colleague, Diane Spicer, but it shows you beautifully the problem that confronts us. Now, let me remind you again of the definition of a cusp, the point where two curves meet. So let's create some curves in the setting of this aortic root. And there is one curve. It's the ascending zone of attachment of the right coronary leaflet within the root. And there is the other curve, which is the attachment of the non-coronary leaflet. So a cusp should be the point where those two curves meet. But you will all know that sadly, we do not call that point the cusp, but more usually it is the leaflet that is called the cusp, where the area that should be called the cusp is called the commissure. And there is yet another problem with cusp, as I'm going to illustrate to you, because oftentimes now the sinus itself is described as a cusp. So we have serious problems. But what about the commissure? The commissure ought to be the area where two moving parts meet. But as we've said, it is the end of the zone of apposition, as in the mitral valve, that most frequently is described as the commissure. So I would like to suggest to you we use alternative words when we describe the aortic root. The moving components can simply be called the leaflets. And significantly, those leaflets are housed within the sinuses. And the sinuses contain the leaflets in semilunar fashion. And then the areas over which those leaflets move when the valve closes, I'm going to call the zones of apposition. I'm then going to emphasize two additional features of the root. First of all, the sinutubular junction, which is its distal extent. I'm then going to consider the area where the myocardium of the ventricular mass supports the hinges and becomes incorporated within the sinuses. And I'm going to also emphasize the interleaflet triangles, the fibrous components of the root between the semilunar valvar hinges. So the root as a whole is made up of leaflets with their supporting sinuses, and significantly it has length as well as breadth. Of great importance is that it extends from the sinutubular junction to the virtual basal ring. And we can see that particularly well if I show you the parasternal long axis equivalent, which illustrates to us the location of the aortic root. As I've emphasized, it is the center point of the mass, the heart rather, so here it's positioned between the left atrium, the infundibulum. We're looking at it from the left side. And its significant feature is the semilunar hinges of its leaflets. And those hinges extend from the sinutubular junction to the virtual basal plane. If we open it out, another picture of Diane Spicer's, we can see the three sinuses. The right one giving rise to the right coronary artery, in the middle, the non-adjacent sinus, the left one giving rise to the left coronary artery. And we see that the distal margins of those semilunar hinges come together at the sinutubular junction. There is nothing, however, at the proximal extent. This is a virtual plane, and it's what we call the virtual basal plane. I am sure many of the cardiologists in the audience still consider that to be the valvar annulus. Note that the leaflet comes together halfway up the length of the root, but take particular note of the interleaflet triangles. Now we can see what's going on in the root a little better if we look at another computed tomogram. This is another one prepared for me and shared with me by Shumpei Mori. Again, we see the center position of the aortic root here, looking at it from behind, between the left atrium, left ventricle, the infundibulum. And you can recognize rather well the sinutubular junction, and then the virtual plane, which we create by joining together the nadirs of those semilunar hinges. But what Shumpei has done to make this computed tomogram, he segmented the myocardium. And there you see the myocardial arterial junction part the way up, be it across the two sinuses of the aortic root that give rise to the coronary arteries. We can see that particularly well when we look down upon the aortic root, this time in a computed tomogram prepared for me by my other good friend and colleague, Justin Tretter. There you see the sinutubular junction, and it is relatively circular, and giving rise here, it's made up of the left coronary sinus, the right coronary sinus, and to the bottom, the non-coronary or the non-adjacent sinus. But look at the virtual basal ring. It is far less circular. It is oval. And now when we compare the dimensions of the virtual basal ring, sinutubular junction, we can see the location of those myocardial components that form the basis of the two sinuses that give rise to the coronary arteries. And this is a particularly important point. In another of the computed tomograms prepared by Justin, looked at from behind, we see the interleaflet triangle between the non-coronary and the left coronary sinuses, and looking towards the front of the aortic root, we see those myocardial crescents that form the basis of the two leaflets that give rise to the coronary arteries. They're important to the surgeons because they provide myocardial rather than fibrous support when the surgeon is placing stitches within the root. They are nowadays the focus of the electrophysiologists because that is where the electrophysiologists ablate the aortic root so as to cause pure ventricular tachycardias. But they are part of the sinus, which is why we should describe the sinus rather than the cusp. Now we also need to look at the way that the leaflets come together when they are closed, and we can see this in this beautiful dissection made by Diane. We're looking now at the root from above, so I show you the left, the right coronary sinuses, the non-coronary sinus, and there are the ends of the zones of apposition, or the commissures. And note that the point, the centroid, the closed valve, is well down within the root. And nowadays you can see this particularly well when you make computed tomograms, this time a two-dimensional one prepared for me by Shumpei. And I'll show you the level of the sinutubular junction, virtual basal plane. Nowadays you can measure height, interleaflet triangle. You can measure the free margin of each of the leaflets, which tells us the effective height of the valve when it is closed and shows you the length of coaptation between the leaflets. So this nowadays is all important as you work out the function of the normal mitral valve. But don't forget the significance of those interleaflet triangles. And I emphasize those interleaflet triangles because they are now going to be important as we consider the abnormal aortic valve. So what are the phenotypes of the abnormal valve, which most times we're going to call bicuspid? In fact, the typical valve has 2 functional leaflets but has 3 sinuses. And that is because 2 of the sinuses are conjoined, usually the right and left coronary sinuses, less frequently the right and the non-coronary sinus, rarely the left and the non-coronary sinuses. But on occasion, the bicuspid valve can not only be bicuspid, it can also be bisinuate. But for those of you dealing with infants, by far the commonest type is the valve that is unicuspid and trisinuate. And here it is the number of interleaflet triangles that distinguishes between these phenotypes. So when we look at critical aortic stenosis, most usually the valve is indeed unicuspid and unicommissural, and it is because it has lost the semilunar hinges of the leaflets that are involved. And paradoxically, now those leaflets are attached in much more annular fashion. Often this abnormal valve is associated with ventricular hypoplasia and with endocardial fibroelastosis. And it's very close to what we might call the hypoplastic left heart syndrome. But when we look at the valve itself, it has a solitary attachment, sinutubular junction, with 2 raphes between the 3 sinuses. So the root itself is trisinuate, but there is a solitary zone of apposition between the leaflets, which is why it is said to be unicuspid and unicommissural. We can see what's going on rather better when we open such a valve, again in this beautiful dissection prepared for me by Diane Spicer. So there is the solitary zone of apposition, or commissure, which comes up to the sinutubular junction. And you notice that that is adjacent to the aortic leaflet of the mitral valve. And I don't think that is coincidental. There is the left coronary sinus, the right coronary sinus, and if you look carefully, you can see those vestigial interleaflet triangles, and that is because the leaflets are now attached in much more annular fashion. And it is this attachment in annular fashion that gives us a solitary zone of apposition with raphes and vestigial formation of the interleaflet triangles. And it produces what I have called the annular paradox. I've shown you that normal leaflets are attached in semilunar fashion, and so they lack an annular attachment. And the paradox is that the more obvious the leaflets are attached in annular fashion, the worse is the degree of valvar stenosis. And that can lead us back now to the valve with 2 functional leaflets. And again, to distinguish the phenotypes, we need to take note of leaflets and sinuses. I've already shown you that the so-called unicuspid valve has 3 sinuses but 2 raphes. So you will not be surprised to learn that when we have the functionally bileaflet valve, we have only 1 raphe. And most usually the valve itself is trisinuate, but rarely the valve can not only have 2 leaflets, but also 2 sinuses. But this is the typical arrangement that we see when we have the functionally bicuspid valve. There you see the raphe. In this instance, it is between the 2 coronary sinuses, and at the base of the raphe, we see the vestigial interleaflet triangles. So that means that only the 2 ends of the solitary zone of apposition now reach up to the sinutubular junction. Thus far then we've talked of valvar stenosis, but when we take note of the aortic root, we also need to remember that obstruction may be present at both subvalvar and supravalvar levels. I can't show you examples of all these variations, but I can summarize them for you. So when we consider subvalvar obstruction, it can be produced by a septal bulge. Oftentimes, that is made worse by a fibrous ridge or a tunnel. And in certain circumstances, the stenosis can be due to tissue tags within the subaortic outflow tract. We can find anomalous tension apparatus, but that is much more usual when we are dealing with atrioventricular septal defect. But remember, we can also have subvalvular stenosis in the setting of a deficient ventricular septation, and that is typically the cause of a deviated outlet septum, but all of this can coexist with valvar obstruction. When we talk of supravalvar obstruction, almost always it involves the sinutubular junction. So it's arguable as to whether that should really be considered supravalvar or part of the valvar problem itself. And we describe it as being hourglass, diaphragmatic, or the true supravalvular obstruction, tubular narrowing of the intrapericardial aorta. But this is the typical arrangement where you see there is a marked waist, sinutubular junction. The leaflets are much longer now than the sinuses, and it is that produces the abnormal function of this so-called supravalvar aortic obstruction. So there are the malformations, and as with the mitral valve, we can understand them on the basis of normal anatomy when we consider not only the mitral valve, but also the aortic valve in terms of a valvar complex. Remember, when we consider aortic stenosis, we should also take note that the stenosis can be present at subvalvar and supravalvar levels. The valvar stenosis we need to analyze in terms of the functionally bicuspid valve, but please do remember all the lesions can coexist. So there we have it, aortic root and aortic malformations.
So an excellent summary of the anatomy of the valve. And now we are moving